some sort of Adobe Flash presentations, full of animations, and some other tricks. My presentation about dermatology psychiatry interface, I'm presenting this presentation instead of Dr. Hassan. She could not fly and come to Saudi Arabia from Morocco. And her presentation also was a case report about dermatology psychiatry unreakable link. I was very impressed by her title, unreakable link, and yes, it is like this. I will talk briefly, precisely also, and about, I will cover 4 points we do face in our psychiatric clinics. Dermatillomania, trichophagia, trichotillomania, and the psychoactive drug rash. Maybe topics. You know, all of us, we know trichotillomania, and all of us, we have cases and patients in our clinics, but maybe the other terminology is not well known or used, but I'm certain that you saw those patients in your clinics. The first is dermatillomania. What is dermatillomania? Dermatillomania is a skin picking, like trichotillomania, hair pulling. Dermatillomania is skin picking. It is a pathological skin picking, repetitive, ritualistic, impulsive picking of normal skin, leading to tissue damage, personal distress, and impaired function. Pathology exists in focus and duration of extent of behavior, as well as reasons of picking and associated with emotions. It is irresistible and intrusive. It is present in teens and starts in early young childhood. This sometimes the patient uses their nails, يلتف شفايفها, the nose, parts of the skin, and sometimes they use tweezers, razors, blades, and knives, القصافة, the boost, benza, to inflect her skin and to take a piece of her skin while she is reading, she is studying, she is watching TV, or she is on phone talking to a friend or something. She has minimizing awareness by the act. Some pick for as long as 12 hours every day, which is often leads to scarring and disfigurement. Most often they pick the face, but many body parts. The most common I have seen in my clinic are the lips. Last patients I have seen, 25 years old female patient, and she is engaged and she is going to marry, and her family decided to treat her because she is unbelievable dermatillomanic patient, and she stays for more than 10 hours every day picking her skin, and they are afraid of the family of the husband coming. Some they use their hands, their fingernails, as we said. Although picking comes in episodes, it increases with the stress times, and sometimes they deny any existence of stress. The reasons for picking: many patients pick relief, discomfort, or tension. It is a part of OCD. Sometimes it fulfills the criteria for OCD. Still others say they pick as a habit with minimal awareness. Itching or uneven skin may also cause the behavior. We have found that the patient may pick several of these reasons. Most report tension before picking, satisfaction during picking, guilt, shame, and dysphoria after picking. Mostly they disfigure their fingers and the joints of their fingers. Anyone hears this dermatillomanic? The fingers? Okay. The consequences, there is social impairment. Sometimes they avoid social confrontation, not to be in a scandal or to live like this. They have sometimes physical injury. The gender, it is tripled in females as it is in males. The onset usually starts in teens, maybe late childhood period, and extends up to adulthood. I have a patient in my clinic now under follow-up for 3 months. He is about 50 years old, for more than 25 years, continuously picking his fingers. 3 steps to diagnose the treatment. Step 1, assess the reasons for skin picking, dermatological or it is medical. atopic dermatitis or scabies or Prader-Willi syndrome. Or it is psychiatric disorder. He has a body dysmorphic disorder or obsessive compulsive delusional disorder or dermatitis artifacta or impulse control disorder. Is it primary or secondary? Step 2, assess picking severity. Is it comorbid with mood disorder and anxiety? Treat skin picking if the patient is preoccupied with picking. Picking causes distress and dysfunction. Picking causes skin lesions and disfigurement. Step 3, provide recommended treatment. For adults, habit reversal therapy plus medication is usually necessary. For children and adolescents, habit reversal therapy alone for mild and moderate symptoms, and habit reversal therapy plus medication for severe symptoms. Is skin picking an independent disorder or symptom of other psychiatric disorder? Although the skin picking is not included in DSM-4, and it will not be included in DSM-5, and the dermatologist refer these patients to you, as a psychiatrist deal with it, it is not found in our classifications, but we consider it as a part of impulse control disorder. If it is body dysmorphic disorder, nearly 30% of patients with body dysmorphic disorder, they pick their skin to a pathological extent. The purpose of picking in bodymorphic disorder is to remove or minimize non-existence or slight imperfections in appearance. Sometimes they can imagine that there is scars, bumps, and bumps. In cases of OCD, the patients may skin picking repetitive, ritualistic, with compulsions, and they say that we try to resist, but usually we do fail. Dermatitis artifacta, patients with consciously create skin lesions to assume a skin roll. We have to roll out this and diagnose it as separate. The evidence based for drug therapy. The only among the literature and recent research is case reports. And case reports, the highest one taking the numbers, it was 28 patients in one research. And they tried different SSRIs. The mostly replicated was fluvoxamine, from doses starting from 100 mg to 300 mg per day, with great results, and more than 70% of the patients improved. Also fluoxetine, 20 to 80 mg per day in several cases reported. Dermatological treatment alone was effective for only 15% of patients. So it is a psychiatric condition. It is not a precise dermatologic condition. Case reports involved in psychiatric and medical comorbidities, they have also suggested that sometimes olanzapine, pimozide, doxepine, naltrexone may be beneficial in reducing skin exacerbations. Fluvoxamine, from 4 to 6 weeks in a dose 100 mg, the recovery rate is more than 70%. Second was fluoxetine, about 30 to 60% improvement. Sertraline was reported to be also of benefit in solitary case reports. The habit reversal. In cognitive therapy, cognitive behavioral therapy, some sort of habit reversal, 5 components in patient learning. I have to educate the patient how to be aware about picking behavior, how to relax and reduce anxiety, how to complete responses to learned behaviors incompatible with picking, such as fist clenching, rewarding oneself for successfully resisting picking, and generalizing the behavioral control. Evidence for habit reversal therapy. Habit reversal therapy has great success in treating and management of dermatillomania. Awareness training, competing responses technique, emotional regulation skills, and psychoeducation. Second was trichotillomania. We know it by heart, defined compulsive pulling of hair, usually begins in childhood or adolescence. Scalp hair is the mostly pulled, but some patients also pull their eyelashes, pubic hair, and other body hair. In females, it is doubled as it is in males. In DSM-4, it's considered as impulse control disorder. It is comorbid with an anxiety and depressive disorder. It is usually episodic. I have very severe cases of trichotillomania, and my longest patient I followed, one patient was total alopecia totalis and reversed her condition fully by hypnosis. Trichophagia is ingestion of the pulled hair. Some patients progress into ingestion of pulled hair. Trichophagia is a form of pica disorder, as if it is a pica disorder and the consequences of trichotillomania or neglected trichotillomania disorder. And typically defined in persistent eating of non-nutritive substance. If undiagnosed, the hair can sometimes make massive clumps and lumps in the abdomen and intestine and causes intestinal obstructions, what we do call trichobizaurus. Patients with trichotillomania often respond to medications used to obsessive compulsive disorder, such as clomipramine and also fluvoxamine. The patient says, I don't want medication. And this was usually is our first challenge. They don't want to be medicated, and they want, and we don't have enough times in our clinics to serve those patients. Initial treatments including fluvoxamine, 100 to 300 mg, and it is the safest among teens. Next is fluoxetine, 20 mg per day for 6 months, hypnotherapy, and now there are great challenge about hypnotherapy, how it is effective. And usually they start for 3 to 6 sessions of hypnotherapy, then the patient can continue with himself by using hypnotherapy tapes. Why do patients pull their hair? According to the cognitive behavioral theory suggests chronic trichotillomania originates in normal response to stress and escapes persons of social awareness. There is a genetic link with OCD, and there is also, they have decreased pain sensitivity. This is the most accepted theory about stress, causes tension, builds bullying, causes shame and guilt, increases more stress, bullying stops, there is stress, and comes in a vicious circle. The medication or CPT in trichotillomania, selective serotonin reuptake inhibitor, as we assured in the beginning, it has an effective value. Cognitive behavioral therapy also has, in special techniques, very highly effective procedures. Obtain a detailed information about the child and adolescent's hair pulling. And there is a chart for doing this. The chart, the teen fulfill it by himself in front of the therapist. The teen must be aware by all the circumstances of hair pulling. Patient can reduce the urge by learning and using awareness training, stimulus control, and habit reversal. Awareness of training involves patients self-monitoring to gain awareness of urges. The child must become alert every hair pulled to be responsible precursors, such as placing her hand on her head. For a patient such, this is a medication here, this is a detailed information about the medication or CPT. Response description. بنسأل patient, نسأل العيان, how many times do you pull your hair each day? How many hairs do you pull each time? From what body areas do you pull your hair? Yani, I don't take it simply or minimize the situation. It is a case of trichotillomania, and I'm going to prescribe anafranil, clomipramine, or fluvoxamine. Also, the response detections. Sometimes I do ask about the precursors and high risk about situations, and do you pull or to create more even hairlines. And we make a diary for the hair pulled every day to reduce the urge, obtain the detailed information, and the patient can reduce the urge by learning and using awareness training, and the child must become alert for every pull, hair, and response. This ball, they call it Kushu balls. Kushu balls, small rubbery balls filled with jelly-like plasma and covered with handrifts for soft tentacles. فيها تلاتيف وفيها شعر. The teen plays with these balls. He has ball everywhere, near the TV, near the phone lines, and he can start to manipulate this ball instead of manipulating his head or his fingers or his lips. rash. I'm going now to sum up and to conclude. Our drugs are not benign, and our drugs, they are not as safe, and they are not innocent. The psychoactive drugs has several types of rash we should be aware of. The first rash is acne vulgaris, acne rash form, and psoriatic rash form. Also, our drugs and our medication causes alopecia and causes baldness and causes hair loss. Also, our drugs can cause eruption bullous forma, and also urticaria and other medication. We should be aware of all these medications. So how is the link between psychiatry and the dermatology? You can expect any drug from our prescriptions to have exanthematous reactions, urticaria, or fixed drug eruption. Photosensitivity, a list of drugs, the simplest and the most common, very commonly prescribed here in Saudi Arabia, alprazolam, causes photosensitivity. Some burns if the patient walked in the sun or went to the beach. Acneiform, antidepressants mostly causes acneiform eruptions. Aripiprazole, clonazepam, and others. Pigmentation changes, amitriptyline, carbamazepine, citalopram, clomipramine, alopecia and baldness, the new generation antipsychotics, the SNRIs, and psoriform eruptions. I remember about 25 years back, I was working in a polyclinic, and one patient of bipolar mood disorder who was under management by lithium. But he gained weight, and we decided together that we are going to stop lithium. And we stopped the lithium. 2 weeks later, the dermatologist in the polyclinic came and visited me. He asked me, what did you prescribe to this patient last time? This patient was under treatment with me for the whole year for psoriasis, and no drug works. I told him I did not prescribe, I just removed lithium. So it was psoriasis-induced lithium. To my surprise and to my knowledge, after 1 year and after discontinuation of most of the medication, the patient had psoriasis back. So that did lithium was the responsible for psoriasis, or who was the triggering factor for this? We have 4 facts about our medications we will conclude about. If your patient develops a drug rash, try to wait 2 weeks before starting a different medication. The benefits of continuing a drug rash, of continuing a drug that causes alopecia, hair loss or increased baldness may outweigh the risks. إلا إذا كانت هي مهتمة إن شعرها بيسقط وده هيقلل في جمالها أو أي حاجة. Sometimes I do prescribe brewer's yeast pills with the medication, and sometimes methylfolate folic acid to guard against hair loss. It works. After discontinuation of the offending medication, drug-related pigmentation changes may take years to resolve. Pigmentation, don't expect that بمجرد ما هتوقف العلاج البيجمنتيشن هيروح. Sometimes it takes years to resolve. Treat the phototoxic rash with topical soothing agents and advise the patients to use sunscreen and to avoid the sun. And I thank you very much. I do appreciate your attendance.
Thank you very much, Dr. Adel, for this exciting and very interesting presentation about the interface between psychiatry and dermatology. Now the floor for discussion. Any questions?
Congratulate you for the great success you have achieved in implementing information technology in Finland. Actually, coming from the same perspective, I would introduce myself. I'm a computerized cognitive behavioral psychotherapy, and I work on promoting different psychological interventions. And currently, I'm working on a program for the use of virtual reality the second line, like having a semi environment. Sorry, I have to say it in Arabic. In Arabic, البيئة
In
المحاكية.
short, please, in short.
Okay. البيئة المحاكية للعلاج النفسي. My question is, how did you manage to introduce information technology in the field of psychiatry in Finland? As I know that Finland is having similar culture, similar issues about having a shortage of psychotherapeutic approaches. And what is your advice to the Saudi health ministry about implementing information technology in psychiatry?
Thank you very much for your question, because this is actually the main idea of what we are doing. I have started this project about 10 years ago, and my first project was ICT-based basic education. And I really had to fight a lot in the psychiatric hospitals, I say fight, and to support that patients also, persons with mental problems has also right to use information technology. We can't isolate them. First, the idea was that they are broken computers, they are doing this and that, but actually now the time has changed, and we have noticed that any harm has not happened. So it's a question about the attitudes. We are, as health professionals, we can be stigmatized as well, and we have our attitudes. And also, the second point is, first was time, second is collaboration. When you work together with healthcare staff as patients and the family members, and if they really think that it's something might be important, so that is the answer. Collaboration.
Thank you. Another question. Yes.
Thank you for your presentation. I just would like to know an examples of the SMS that you sent to your patients. Just could you give us some few examples of the content of the SMS?
The content of the messages to you. Okay. This is very, very interesting and nice process when patients themselves decided the content. Of course, they have to be very short, because they cannot be, our patients' telephones are very simple ones, so they can be too long. So they can be simple. Please remember, take your medication. Please don't wake up too late. Remember to do this and that. They say that they also have to be some kind of jokes inside, because they didn't want that it's too serious. And what was interesting, that our healthcare personnel were actually very angry with the content of the messages. Why these kind of stupid messages will be sent to the patients, and we expect patients themselves has decided the content. So there's a long list of messages, and it's really therapeutic when patient can choose what kind of messages. It can take a long time, what time, evening, morning. And if they don't get the message, they call to us. Now there is some problem with the system. So they are really engaged. They can even call that I should be involved in this trial, and my staff members have not asked about my permission to be involved. How I can be involved in this project? So they are really motivated.
Thank you very much. My question for Dr. Marie. Do you think probably sometimes these messages may enhance more disorganization for the schizophrenic, especially those who are paranoid? And the second question, what is your selection criteria for this kind of schizophrenic patients?
This is a very good question, and I think that those who are paranoid have refused to participate. And we have also a rule that if the psychiatrists think that this may be harmful for the patients, so they will be excluded. Our inclusion criteria are age between 18 to 65. They have a neuroleptic, and they are discharging from the hospital back to the society. And they cannot be patients who have done some kind of crime. They can be the specific intensive unit. Actually, that's all, because we have tried to keep our inclusion criteria as simple as possible. Next project, we don't have any other exclusion criteria, only age. They cannot be under 18.
Thank you. Last question for Dr. Adel, please. Dr. Adel? Okay.
Thank you, Dr. Adel, for this comprehensive lecture. I would like to ask, did you encounter cases of allergy in Stephen Johnson syndrome related to carbamazepine or lamotrigine?
Yes, this issue only has about 80 slides about the syndrome and about lamotrigine and other anti-epileptics. Other anti-epileptics also is reported in most of the medications. It is not only lamotrigine responsible for it, but it is replicated and reported several times with lamotrigine. Of course, should be taken into consideration.
Some patients swallow the pill after following it, and this leads to something, it needs surgery later on. You see, in a case like this, we call them Rabatzi syndrome. It's a historical thing related to this condition.
I had only one patient, I saw it about 15 years back, and she passed the surgery, and we were in query, is it only hair pulling and trichophilia, or it was factitious disorder, because she swallowed things other than hair also.
Thank you very much. Many thanks for all of you. Many thanks for the speaker. Thank you very much.
So, DJ, I would like to thank you for coming and lecture. Professor Benita. Professor Mustafa Sadani. Dr. Adel Serag.